And is he in the right? Oh, there we go. Okay, great. Thanks so much, Eric. I appreciate all you've done. And this keeping track of all this AV stuff is important, so we appreciate you. So for those of you who are just joining us, hello and welcome to session 2 of ConnectED 2026. It's a mini summit program sponsored by the Thyroid Eye Disease Community led by Christine Gustafson. And good evening, good afternoon, and good morning, depending on your time zone. We have 37 states and 12 countries represented today, with Dr. Pakdel coming to us from Prague today at the World
Actually,
Ophthalmology.
I'm in California now. I
Oh, you're
just
in
arrived a
California?
few
Oh,
hours ago.
okay. Oh,
Yeah.
okay. You just landed. Okay. Well, thank you for joining us on such a tight schedule there. But my name is Carol Bowden, and I'm a thyroid eye disease patient and pharmacist. And throughout my career, I've worked in the hospital, in the pharmaceutical industry, and in academia. And I've had TED for over 5 years. And of course, I have a keen interest in supporting other TED patients and perhaps help them better navigate their journey as well. In the previous session, Christine, Dr. Douglas, and Dr. Sunday have explored the physical, emotional, social, and psychological impact of the facial change and identity. And now we'll begin the second session, which is entitled The Pathways to Healing, and followed by the treatments, restoration, and renewed confidence, where we will engage this evening in a conversation on the current treatments, surgical and rehabilitative approaches, and some of the emerging and practical pathways towards recovery. And joining me, we have a distinguished panel of experts. I feel very fortunate to be on this panel with all of you, and they will, of course, answer some of your questions as the audience. So why don't we go ahead and dig in and get acquainted with our panel. And Dr. Van Landingham is from the University of Wisconsin. We have Dr. Nguyen of West Virginia University, and finally, Dr. Farzad Pakdel from the University of Southern California. And behind the scenes, you've already sort of met if you've been on session 1, Dr. Jen Helfer of Viridian Therapeutics, who has compiled a list of questions that you, the audience, had helped her develop during the registration. And similar to what we saw in the previous meeting, Jen will ask a sampling of these questions in the last minutes of this session. So I was wondering if first of all, if each of you of the panelists can share a couple of sentences about yourselves and your work in thyroid eye disease. And first, I should say that all of these physicians are oculofacial ophthalmologists and surgeons. So, Dr. Landingham, let's start with you, please.
Sure. Thank you so much for the introduction. I'm so glad to be here. I love what your group does. I know a lot of my patients really do too. So, as Carol mentioned, I work at the University of Wisconsin, Madison. I'm associate professor of oculofacial surgery here, and I treat patients with thyroid eye disease, mostly from kind of the upper Midwest. I see folks from all over Wisconsin, some from Michigan, Minnesota, Iowa, Illinois. Um, yeah, and happy to be here and happy to be a resource for all of you here tonight.
Great. Thank you very much. And then Dr. Nguyen.
Again, want to echo Dr. Van Landingham. Thank you so much for having me on the panel. I've been in West Virginia for about 20 years. I direct the fellowship program as well as run the oculoplastic service at the university. Similar to our panelists here, we do have a thyroid disease clinic that we see patients, and my patient population in Appalachia, Mid-Atlantic area, and really excited to share our thoughts along with our colleagues.
Great. Thank you very much. And Dr. Pakdel.
Thank you, Carol. And Good afternoon, everybody, and my dear colleagues here, and also our dear attendees. I'm Farzad Pakdel, occupational and ortho surgeon, and I'm working as faculty member in University of Southern California in Los Angeles. I had the opportunity to work and actually be in contact with my patients with thyroid eye disease, and I had the opportunity to actually be connected and helping my patients over more than 10 years. I've done research in that because of my interest in this disease, and I'm very grateful if I can do more in future for my patients in terms of improving myself and skills in terms of research and learning more. Thank you.
Great. Thank you so much, all three of you. So I think we're going to have a great discussion here today. And why don't we start off with a first question here is how has the TED treatment landscape changed over the past decade? And Dr. Van Landingham, perhaps you can begin just talking a little bit about how it seems that there maybe is an increased awareness of thyroid eye disease. We see commercials on the television for that sort of thing. Talk about maybe some of the biologic medications and also the component maybe of shared decision making and how the patients participate in that discussion and any of the improvements in digital approaches. And any of the other of you, feel free to chime in as well so we can have it more of a conversation here.
Sure. Yeah. So I think TED treatment has changed immensely over the past 10 years. And I think the biggest change has been in the way TED is treated medically. So kind of for background, which I'm sure will be review for many of you, traditionally, we think of TED as having kind of an active phase and a more chronic, quiet phase. And certainly not everybody's experience of the disease fits these labels. But again, it's kind of the traditional framework is trying to divide it into these two general phases. And during the active phase, ideally, we're treating medically to kind of quiet down the severity of the disease and help make it so that the individual ends up with kind of fewer challenges later to address, potentially by a reconstructive surgery or by other means. Again, bit of a simplification, but and historically, I'd say before 10 years ago, really the main tool to use for the patient with the active TED was steroids. Steroids are really powerful. They can really help people, but it's a really blunt instrument. It's not specific to thyroid eye disease. And it was kind of all we had for a while. And within the past 10 years, there's been the development of teprotumumab or Tepezza, which of course is now, I think, really a game changer for a lot of patients with thyroid eye disease. And as of this past week, a second FDA-approved medication for thyroid eye disease, veligrotug, and I may be not saying it. I'm sorry, I'm still just getting used to it. But now there are two FDA-approved medications specific to thyroid eye disease. Again, huge game changer. In addition to that, other drugs are in the pipeline, which I'm sure we'll really dive into tonight. And some older medications that are being used off-label have been just studied more as well. So maybe past 10-ish, 10 to 15 years have been publications about use of mycophenolate, which has been around longer, rituximab, which has been around longer. Again, not specific to thyroid eye disease, but there's just kind of more data about how those can be used for the right patient in the right setting. Actemra, which is not an old medication, but that one has also been studied despite it being an off-label use. So I think there's just a lot more information about both new pharmaceuticals and existing pharmaceuticals, how they can be used to help patients medically with thyroid eye disease.
Great. Thank you. Anything, Dr. Nguyen or Dr. Pakdel, that you'd like to add?
What I think Dr. Van Landingham highlights really important is that, the revolutionary changes in specifically the insulin IGF receptor monoclonal antibody treatment that's really impact. I think most of the time we think of TED as she mentioned, active and chronics, but I think, we've seen in literature and my patient use in various different phases, if we want to divide it out, but of IGF receptor that can have impact on patients. And particularly is, I think, often not described about is in low activity, chronic patients that can have quite drastic change, in some cases can, preclude the need for surgery. And I think, in addition to that, it's kind of add to the combination treatment, some patients may just need IGF receptors, some may need additional combination therapy or surgery that we have not thought of. I think in the beginning we were so caught up about, well, could IGF receptor is the only thing, but I think it's a really big tool in toolbox that have complement the overall treatment paradigm of TED.
Yeah, great. Thank you. And Dr. Pakdel, I don't know, and maybe the others can chime in on this one too, but how shared decision making with the patients how this aspect has evolved, as well as working as a multidisciplinary team, and maybe a bit about how that works at USC.
Yeah, actually, great things are happening. And that's a great news for the patients based on our understanding the pathophysiology and emergence of the new targeted treatments. And we are seeing that the number of clinical trials on new medications are rising, and they are very promising to have like more effective and safer medications in future. And then for now, we have actually the options to customize based on the patient's need in terms of medical and surgical treatment. And then based on the patient's demand, we can offer new and like standard anti-inflammatory medications. So when we are talking about the rehabilitations, we have a couple of, surgical techniques. We learn to do a lot of, surgical methods, not just like the traditional orthotic compressions. We know how to deal with the minimal incision surgeries to increase our effectiveness and safety of the orbital decompressions and ID surgeries for now. And I think one of the most important things that my dear colleague also mentioned is that customize the treatment plan. It means that we need to tailor what our patients need to improve their quality of life, not just saying, hey, you are in the active phase, you need to take medication A or B. We need to understand what's the patient's demand in every phase. The other big change I may add and flashback to your first question is that now, in contrast to 10 years ago, if you ask somebody what happened when you were actually answered that what can you do for now when you have active thyroid eye disease or chronic disease, many of us maybe provide some answers. Hey, you're not in a suitable time frame for doing operations. You need to tolerate your proptosis. You need to tolerate, that, eyelid and facial changes for a while, like 1 year, 6 months and more. Then let's see what's happening next. So it's frustrating for the patients. So we have done studies on quality of life personally. I have seen that quality of life is seriously damaged in patients with thyroid eye disease. It's not easy to ask a patient. That's, sometimes these patients are depressed or anxious. So it's not easy to deal and say, hey, we cannot do anything at the moment. But for now, we have new options. We can offer, hey, we can do such a thing. Medical treatment for your eyelid changes or medical treatment for your proptosis, or we can decide to do earlier surgery for you or combine different medical, surgical together to increase the efficiency of treatment. And I'm very happy that the new science are helping us to provide maybe easier customization of the treatment for our patients using the AI. So in the past few years, we learned AI, and each of us, like academicians and physicians, are it's our mission to learn the new technology, new science to help our patients. So we are doing like new research, how we can have better understanding and earlier diagnosis and a new dimension perspective on the diagnosis, and then customized treatment based on the bunch of data we have using the AI for our patients. So, and then we have like a couple of apps that can help patients themselves to customize and help them to investigate their changes over time, even though they are waiting for our visit then. So it's just a very summary, very squeezed, addressing your question.
Yes, no. Well, thank you for that. And I can certainly relate to the, you're saying to kind of wait for a period of time. I had the diplopia, the double vision, and I literally had to wait 5 months wearing a patch on my eye until I could have the surgery because they said you have to be out of that active phase and in a more stable phase before you can get surgery. And obviously, I mean, you learn to live with it and you do what you have to, but in the meantime, it is kind of an inconvenience to have to kind of walk around like that. So your point is certainly well taken there. And we're wondering, Dr. Van Landingham or Dr. Nguyen, if you could talk about the multidisciplinary approach. And what I want to kind of get at is how, because for me, I have so many physicians, right? You have an endocrinologist, I have my oculofacial ophthalmologist, I have my strabismus surgeon, and I have an ENT who did my thyroidectomy, amongst other, and then eyeglasses and all the other. How do we make sure that we have all of these different individuals talking together? And any of the three of you can, I see Dr. Farzad, Dr. Pakdel also nodding his head. So please, if you'll comment on that as well. And in
For our I guess in our area, I think what you describe is a common experience and I think it's very nice that a patient have a lot of providers because we are each specialized in our own area. And I think together, as you mentioned, as a team, you need an advocacy, somebody who advocate for you. And I think the eye is unfortunately kind of having a big impact, for the patient because it affects, as Dr. Pakdel mentioned, the quality of life, whether that's depression, anxiety, for which I don't think we talked about earlier, because, a lot of times, you can have the medical issues, whether weight loss when you're hyper and then you have weight gain when you become, youth, or you regain some of that back, whether you have radiation or you have thyroidectomy, for which you see the ENT surgeons, and then you have kind of a long-term follow-up with your endocrinologist kind of monitoring that, and then you have somebody like all of us on the panel here to kind of manage your eyes, and it have different periods while you're getting treated, whether you have proptosis, double visions, or lid retraction, along with other eye symptoms that we don't typically may not be highlighted or describe, or patient may not mention before. So I think at least for me, I think for most of us here is I think having an advocate, kind of somebody almost like a care manager in terms of I work with my strabismus surgeons to kind of because I don't do strabismus surgery myself, so I work with orthotists as well. So I think having an advocate, somebody kind of a main driver for that, kind of in a way guide patients through some of the impact, whether thyroidectomy can stabilize the thyroid itself, but also help maintain the risk for any worsening of thyroid disease. Also, having maintained your thyroid with your endocrinologist is important. So having that close communications, for us is mostly electronic medical records. But I'm not afraid to call up the endocrinologist if they suddenly I notice on the lab that they somehow out of range, that need to be arranged. So I think that the key is, I think, communications, and I get passionate about the patient's thyroid disease to kind of reach out to kind of arrange all of that. So, but I think what your story described is a successful one. I've seen patients who, they may be seeming first and maybe waiting 3 months to get an endocrinologist. That's a first start. Or patients who come in, as of, somebody who thought they have allergies and they've been going around, with, optometrists or primary care that, been treated for that. So I think that's important for us to kind of recognize first and kind of help coordinate the care. At least I feel that we need to help advocate for our patients. And I'm kind of interested how our two colleagues if they have any differences or any things I can learn from there.
Yeah, so there are a handful of centers, mostly universities, but a handful of centers around the country where there is a like multidisciplinary thyroid eye disease clinic where that coordination is done in a structured, a formal way. For instance, with a designated nurse navigator or care coordinator. I regret to say I don't have one at my institution yet. We're sort of exploring that. But if that exists in your area, that kind of model, I think can help because it does often, I mean, I think patients for good reason often feel kind of a burden of having to do a lot of that coordination themselves, which can really be a challenge. So I would say kind of if available in your area, it can be helpful to have a clinic that in a formal way sort of organizes the specialists. I think even without that, it can be helpful to try to keep the specialists at least in one health system if possible. So for instance, if you go to, say, the university practice for your oculoplastic surgeon, if you can kind of also see the endocrinologist within that same ecosystem, that can make it a lot easier for clinicians to communicate with each other, see each other's notes, see imaging. For instance, if you're getting a CAT scan, I can, get those images if they're performed outside, but it becomes a little more frictionless if it's all in one spot where possible. I know that, people are often working with the uh, uh, challenges of geography, insurance limitations, this and that. But those are some ways that you can kind of try to focus your team.
Mhm. Now, you mentioned that there were some thyroid eye disease multidisciplinary clinics in the country. Do you know of the names of any of them right off the top of your head, or?
Yeah, so I have to say I'm a little bit slim on details because again, I
Okay.
don't specifically work in one. I know Mayo has
I
one.
was wondering, yeah.
Yeah, which I've heard great things about. John, Farzad, feel free to jump in as needed. That's the one kind of in my region that I'm thinking of off the top of my
Okay.
head.
All right.
Yeah, I think, we just like Dr. Van Landingham mentioned, I think there's centers that, the Thyroid Center, Eye Disease, Center of Excellence, that I think, patients can typically Google or search for those. But I think most ophthalmologists or eye care providers in the area, I think, given how prominent thyroids have been known, within the past 5 years, 6 years now, that I think most know of somebody in the area that can kind of start a process or not part of that network. So I think throughout the country, it may not be a formal center of excellence, but I think it could be various universities center or TED center can be referred to. And I think that the challenges is hard to know, not every ophthalmologist are well versed or know of those centers, but I think it gradually, I think we're building up that capacity to kind of get the patients to get referred earlier to these kind of multidisciplinary team.
Yeah. Okay. Great.
So,
Thank you.
Carol, may I add something?
Absolutely. Please do.
Okay. Actually, as Suzanne and John beautifully mentioned about the role of multidisciplinary team and how the interaction between us and different specialties can increase the actually the outcome or services for the patient. One of those measures can be like thyroid eye clinic, but it's not the only one. Although we have a lot of challenges, especially in terms of thyroid eye disease, as Susan and John know it's not easy to get together like different disciplines at the same time in one clinic for hours and just talk about one patient, because it's very important. Maybe you can help us to advertise thyroid eye patients need a lot of time. We need to put a lot of time, consider a lot of time for care of patients, not only in the clinic, in the home, in our office, in communicating with each other. But the thing that I would like to highlight is one of us in terms of the multidisciplinary team should be the leader. Maybe Suzanne, John, and I should take the responsibility to be the leader of that multidisciplinary team when we have a patient with thyroid eye disease. I invite my, endocrinology, maybe immunologists, MR, neuroradiology, maybe other disciplines, psychiatrists. Hey, join us and help. How can we improve our services for our patients? It's not necessary for every thyroid eye clinic. I invite many of my dear colleagues and keep them away from routine work. So maybe endocrinology is one of the persons that really help us in terms of the management of thyroid eye disease, but it's not the only one. So what I'm trying to say is that Suzanne, John, and other dear colleagues, we can actually just lead the team and invite different persons in terms of the online or offline, in person or offline to help the patients.
Well, I can tell you that as a patient, we would all appreciate that a lot, because it is something that we do, I mean, whenever I had my surgery, I'd text or I'd email my endocrinologist and say, hey, I just had my surgery, FYI, just to keep you in the loop, and I would do that with all of my physicians just to kind of facilitate that. But unless somebody thinks about that, that might not be intuitive for a lot of people. So we would be grateful anything that you guys would do. So why don't we move on? And I want to ask, so if in patients who have thyroid eye disease, some of them might look at more alternative therapies and other types of things, and just sort of supportive care. At what point do you think, or maybe you can kind of talk about, do we begin to become more aggressive? At what point do we need to suggest to a patient, oh, you know what, this is something we really need to get taken care of? Any comments on that? Break points for when patients can speak up a bit more? Okay, Dr. Pakdel, sure, since you shut yours off.
Oh, sorry. So I was actually that's a great point, because sometimes we face patients that need immediate or maybe more invasive actions in terms of this saving the function of the orbit and the eye in terms of vision, especially the vision. And sometimes it's more critical than the vision, it's the life. Sometimes we are facing patients that have comorbidities, systemic and ocular, and needs great attention for that. So maybe some treatment is better than the other, standard treatment for that patient, or we need to just seriously negotiate and discuss with the patient. We need to do a surgery to save or improve your vision, and we have very limited time about that thing. Yeah, there are some medical conditions we need to be more invasive, and maybe we have limited time for decision making, especially with those recalcitrant or non-responsive patients in terms of like this thyroid optic neuropathy. These patients are referred to us with several treatments, even sometimes orbital decompression. Still, the patient shows worsening of the vision. So we have a very short window for decision making. We have actually less options, and then we need to just start treatment right away.
Mm-hmm. Yeah.
I think things to think about from a patient perspective are, if you're noticing your vision is getting worse, that's something that, you absolutely want to be telling your doctor about right away, just because that can be a sign that we do need to kind of pull that trigger and act more quickly, perhaps, than we might have otherwise done, whether it's medication or surgery. And I think certainly if there are any changes, this is a disease that can be a little unpredictable. I might see somebody and say, oh, things are pretty stable. We'll see each other back in I don't know, 4 months or something, and then we'll plan for next steps. But if, you're in kind of one of those holding patterns, and all of a sudden you're developing double vision, or your double vision is changing, or your eyes are hurting more, any changes kind of in those between visit times are things that might prompt a reconsideration of the plan, and definitely you'll be assigned to reach out to your doctor and try to kind of restart your ongoing conversation.
Great. Great. Thank you. And
One,
go ahead, Dr. Nguyen.
I think we also want to empower patients as well. I think a lot of times, I see patients come in looking for treatment, also kind of feel I don't know, guilty, like something had happened or that something may have done that to them. Even though sometimes patient may have a lot of family history that predispose them to that. But I think, we all kind of think about, healthy eating, antioxidant diets, I think important for us. I think we've seen that, I think the YouGo group have shown that, using selenium for first 6 months of life, of TED diagnosis can decrease some of the inflammations. Typically does not improve with the proptosis and double vision. But I think that kind of give the patient empowerment, that's something they can control for disease that they feel like they have no control. Certainly in my regions, smoking is highly prevalent. So though it's hard to change that behavior, but I have seen success where a patient just suddenly stop smoking. They realize that this is something that could blind them. And so I think some of these kind of non medical or non-surgical, I think give empowerment to the patients that they can do something to control. I have patients who gone to kind of more naturopathic, or how we say, or more natural eating, not just antioxidant. And I think they give them comfort that they eat healthier, and maybe perhaps that all of that help them kind of feel confident that you can walk with them through the journey of treating the TED.
Yeah, no, I think, and gosh, great. Thank you. That actually dovetails nicely into my next question, which is sort of around what approaches can improve the comfort and quality of life, which you've already touched on. And they talked a little bit about nutrition in the previous session as well. But also maybe talking a little bit about mental health support and other rehabilitative strategies. So, for example, when I had my double vision, I could only see out of the bottom of my eyes. So, as a result, I would drive like this so that I could see out the bottom. Well, my neck, I eventually needed a physical therapy for my neck because I had looked at it for so long. So talk about some of those little oddity things that might come up that, as well as, I shouldn't say oddity, but the rehab things that we may not have already touched on in the first two sessions or first session here. Dr. Van Landingham, let's start with you. Sorry.
Sure. No, it's all right. I think, like you mentioned, everyone's experience is so different. And, most people won't need neck PT, but that is absolutely a part of it for you, due to the double vision.
Yeah.
I think you mentioned support and kind of psychological support, emotional support, which is so important for, I think, a lot of people walking this journey, but probably most patients. I think, I really love what the TED community organization does. A lot of people who have TED don't necessarily know anybody else with this disease. I think it's a great way to connect with other patients who are maybe in even different phases of their disease, kind of have maybe sat with it longer and can kind of, share their experiences and their kind of tips and tricks and just thoughts. And I think, everybody kind of has their own sources of support, but I think drawing on those sources of support that are, have always been valuable to you as an individual. So for some people, that's their family, their friends, their faith community. Certainly, for some folks, seeing like health psychology can be helpful, like either establishing a therapeutic relationship, or somebody already has, a therapist they trust. That can be a good person to work with as well. So I think those are kind of important people to integrate into your sort of care team early on. And I think sometimes that does mean, like, as one feels comfortable, maybe proactively bringing TED up earlier. Maybe like if it's saying you're kind of processing and you think about, well, who do I normally go to when I want to discuss something important, when I want to feel cared for, maybe if that person's your mom or your sister or someone, call them up on the phone, get them involved, kind of explain what you're learning. I think that can be a really great to have supports throughout the journey. That wasn't to the physical side of things, but to kind of the emotional side of this journey.
Sure. Yeah. Well, yeah. And thank you. And that, that is very true in that, and we have Christine mentioned in the first session that we have a storytelling workshop where we learn how to tell our story to our caregivers, our people at work, our, our employers rather, and so forth, just so that, because they can be difficult conversations and you don't know how much to tell people, how much do they really want to know, how much, and so that's something, I guess that's another topic, but I wanted to put in so that our audience is aware that we do have this storytelling workshop that's coming up as well. Dr. Nguyen, did you have anything else you wanted to add to this one?
No, I want to highlight what Dr. Van Landingham mentioned about how the TED Connect organization have been quite helpful for my patients. But I also want to add that, with the various, sorry, it's very specific to the biological treatment, but the patient access liaison, for the IGF receptor have lots of experience. Because to me, I may spend half an hour or 45 minutes with a patient in clinic, but, as I go through this journey, it could be, 6 months, a year, or various time. And then, I find that, the patient access liaison for various IGF receptor, deal with many patients, and everyone's different in terms of what impact them primarily, whether it's the, proptosis or the photophobia. I mean, all of these different symptoms. I find that, these are very seasoned people that, can walk patient through, or kind of hold their hands throughout the journey. I just want to kind of highlight that, really appreciate that support that many times that they're not being recognized for. So I think unfortunately we don't have something like that for surgery. And I mean, I can tell them about the bruising, and then all those things, how long it may take to recover, but it just I think that there's really a lack of need for, which I think the TED community organization kind of as a whole comprehensively kind of put it together nicely.
Yeah. Oh, no, absolutely. And your nurse coordinators, I think they help the patient as well, not to discount them either. But I know that what they called PAL, that, Horizon or Amgen had, helped me through my Tepezza therapy tremendously. I mean, because there were things that I was like, oh, is this normal, or is this, and they could really say, oh yeah, we've seen 100 patients that have had that or whatever, so that it would put my mind at ease that, okay, now I know that, everything is fine. So I totally agree that the PALs, the patient advocacy liaisons, whatever their titles were greatly helpful. And Dr. Pakdel, did you have anything you wanted to add here?
Yeah, thank you very much for addressing this very important, super important issue, because when we are talking about thyroid eye disease, it's not just a medical condition. It's like maybe it has another hidden mental and psychological aspect of view. Let me bring you all of us know because the factor for actually disease and responsiveness to different kinds of treatments for thyroid eye disease. So for years, we learned that we need to counsel the patient to explain what's the effect. It's just oversimplification, because I've seen a lot of my patients, they do not quit smoking. Actually, I learned that I should know more about my patient. Why should he or she is smoking? How can I help my patient to quit smoking? Not just give some advice. It's not enough. We should make sure the patient can quit smoking for some means. So if we do not address that thing, we cannot help our patients. And another important point is that if we cannot see that other perspective, the patient may not be adherent to treatment. I mean, if the patient cannot quit smoking, the response to your treatments, your expensive treatments, your surgical treatments may not work. The patient will show some recurrences. This is the thing never of us want to see. So it's very important that we can actually acknowledge this perspective of the thyroid eye disease in our patient, not just the amount of proptosis, not just amount the diplopia, but the whole human body. And then we need to address that thing. And then actually I learned that this is like a journey for me. When I have a patient with like thyroid eye disease, like orbital tumor, it's like a journey. My patient and I started a journey together with my other wonderful colleagues together. And then we need to help us learn from each of other what our demands, what we need to do, and then formulate the treatment for our journey to make sure we are reaching the thing. And then about thyroid eye patients, in each visit I provide some perspective, what we were and what we are now. If we are not progressing well, I analyze why we are not progressing well. And then we are doing well, I highlight these are the new points and celebrate this together. But my patient now very happy that you're showing some improvement in everything. So it will show the patient that you're enthusiastic, you care about them. And then this is a journey you should do together.
Yeah. Oh, absolutely. Well, I certainly like your approach in doing that. And it sounds like when we do get these multidisciplinary teams together, the smoking cessation team has to be included. That's another component of it. So why don't I know we just have a few more minutes, and I have a couple of other questions I want to do, and we haven't gotten to the most obvious one, and that is, what role does surgery play in the recovery journey? Maybe talking about the different types of surgical procedures that are conducted and then are performed, and then also talk about the functional versus cosmetic outcomes, and maybe the issue of setting up realistic expectations on behalf of the patient so that they understand what to anticipate. So, Dr. Van Landingham, let's start with you.
Sure. So, excuse me. As I think many of you know, not every thyroid eye disease patient needs surgery. And those who do, it can look very different, kind of depending on the individual. I kind of think of three different main categories of surgery for thyroid eye disease. One is orbital decompression surgery. Two is strabismus or double vision surgery. And three is eyelid surgery. So the decompression surgery is done most commonly for patients with proptosis or eye bulging. Also, especially for folks who have optic neuropathy, so who have that vision loss due to compression of the optic nerve. That surgery is typically done first in someone who requires multiple steps. And in that one, we're either removing some of the bones around the eye and or some of the fat behind and around the eye in order to allow the eye to kind of go back into the head, sort of reduce the amount that it's bulging. Again, that's typically done first if it's needed. Strabismus surgery, which is used to treat double vision, is eye muscle surgery. Often that's surgery is performed by a different specialist. There's some thyroid eye disease, oculoplastic surgeons who do kind of all three of these categories. For many folks, they end up needing to see a strabismus doctor, often who operate also as pediatric ophthalmologists, interestingly enough. So that kind of is the second phase in patients who need more than one phase of surgery. And then finally comes eyelid surgery. So for patients who have eyelid retraction, like their top eyelids are too high or their bottom eyelids are too low, they may need surgery to kind of adjust the position of the eyelids and help the eyes to be properly protected by the eyelids. And again, this is very customized for the individual. When possible, we like to make sure that the patient's thyroid eye disease is stable. It's not actively changing before we do surgery. The big exception is in those folks with optic neuropathy, where we're needing to operate more urgently to save vision. I know you mentioned a little bit about sort of cosmetic versus kind of functional surgery, and it's interesting. There are a lot of thyroid eye disease surgeries where is this cosmetic, is this functional, or like medically necessary, where that's unambiguous. Say someone has double vision, no one's going to be trying to tell them that's a cosmetic surgery, or at least they shouldn't. So typically that's something that's straightforward to the patient, to the doctor, to the insurance company. I think where sometimes the word cosmetic starts getting thrown into the conversation is particularly kind of at the eyelid surgery phase of things, where there are times where, say, an eyelid surgery maybe isn't necessary to allow the eyelids to close properly and protect the eye, but is necessary for, say, restoring a person's baseline appearance. And I think sometimes when you get to those discussions, then there can be challenges. I think particularly when we're trying to ask insurers to cover surgery, to convince them that is sort of a medically necessary step. Yeah, so that's sort of when those conversations start happening. Yeah.
Yeah, I found it interesting when I had my strabismus surgery. Although when I had the misalignment, it wasn't all it was noticeable, but it wasn't all that severe. And then after I had my surgery, everybody said, "Oh, your eyes look great." And I'm like, it's the fact that I can see one. It's not that my eyes look bad. It was that I was, and people forget that, or people outside of our group here forget that, and you're like, oh my gosh. So and I see that Jen is coming on here, getting ready to ask, but I might let Dr. I don't know, Nguyen and Dr. Pakdel also make quick comments before we turn everything over to Jen here. Dr. Nguyen, please.
Yeah, I want to add that I think the IGF receptor treatment have really, I think, changed the traditional, thyroid surgical management. I think we know from studies that, surgical treatment overall, I think, have dropped or decreased thanks to the powerful impact of IGF receptor. I think we see, at least for me, I think it impact patient in a way that it decreased the need for surgery, but also the order of surgery have changed, meaning, a lot of times proptosis improve, and along with the pupil improvement, and they do improve, for many patients, the lid retraction, but that may not be sufficient for whether they're still having mild lack of thymos or still some dryness or SLK, superior limbic conjunctivitis from the lid retraction, for which, some lid retraction repair may be helpful. I think we don't have any data. We don't think that, IGF receptor have big impact on lid retraction itself. So I think for patients who are mostly lid retracted, IGF receptor, I don't think are known to do that. So I think, as times go on, these the role of surgery, I think it will be refined in terms of changes, in terms of how do we incorporate these in. So I'm very excited. I don't think there's any paradigm yet. I think everyone has kind of their kind of wait and see approach, perhaps, or maybe their technique of how they combine biologics and surgery. So I think, it's kind of wait to be seen of what a better paradigm will be, turning out in the future here.
Yeah, it'll be sort of be a balancing act here. So, and then Dr. Pakdel, I'm sorry to give you such a short time frame, but if you don't mind making a couple of comments, I'd appreciate it.
So I believe many of the important things actually Suzanne and John mentioned, and then I can add something that now we have more options. I would like to say this is the treatment. Maybe we can emphasize that over time we may decide to restart medical treatment or continue medical treatment for a while, not just 1 or 2 sessions, courses. So I provide enough information for my patients because when you expect as a patient that this disease will go away after like 8 courses of such a treatment, if the disease come back, you're not happy with that. So I try to explain maybe we need more interventions in future, but we will do our best to control the disease by surgical, non-surgical means, and we have plenty of options for now. We can do non-surgical medical decompression for some patients, even in the chronic stage, that many of the patients may help with that, or the patient may need both surgical and medical treatment at the same time. So these complementary treatments are essential. I don't like to say, hey, this is just medical, this is just surgical case. We need to combine everything together to make sure we have a good result for our patients.
Yeah, I think that's a good point and a good sort of area that we can sort of end our conversation at this point and move on to the questions. Before we do that, I want to first thank all three of you because I won't be coming on again, but I feel honored to be able to spend some time with you, and thank you. And we're really grateful for your feedback. And we can see from the participants, everybody's kind of hung on here for the full 2 hours. So that's an awfully a good sign. Also be aware to the general audience that there will be an after party after when Dr. Helfner is finished. And that is a time when, if you choose, you can put your camera on and ask questions of the surgeons, whoever can stay on. We're not sure. I know Dr. Sunday is still on, and hopefully our three people here will have a chance as well. And you can kind of listen to people's questions if you don't want to turn on your camera, or you can obviously speak up and turn it on and interact more more in person. I also wanted to mention that there's another mini summit in the late summer and fall that is planned. And that will focus on the interplay of TED and Graves' disease. And now, without further ado, I will hand the program over to Dr. Helfer.
Thank you so much, Carol. So hello again. For those who weren't at the first session, real quick, I'm Jen Helfer. I'm from Viridian Therapeutics, but my role today is to ask this panel of experts the questions you all submitted during registration. There were over 150 people registered, so there were a lot of questions, so we're definitely not going to get to them all. But I pulled out a few that really relate to the conversation, as well as some that haven't been asked yet or haven't been discussed. So I'm going to kind of rapid fire these because we're getting close to time, but maybe Dr. Nguyen, I'll start with you. There were quite a few questions about the relationship between Graves' disease and TED, and specifically thyroid removal, and can that benefit TED as well?
Yeah, I think we seen that many times thyroid disease may be occur concurrently with Graves' disease of hypothyroidism when the patient first diagnosed. But there's patients who may have it before or develop after. But I think the majority we see patients with TED have Graves' disease. So therefore, I think having a well-controlled hyperthyroid status states, whether with medication or surgery, is important. Within my endocrinologist group, typically we like to kind of have medication adjustment to make sure that they become euthyroid as quickly as we can and maintain that to decrease the progressions of TED. However, for those who could not maintain the euthyroid status, surgery is an option. I think the more probably being utilized just because rather than radiation, because the fact that it's prevent the release of the antibodies by radiation treatment. And I think having a thyroidectomy important to make sure that the patient get they could become hypothyroid fairly quickly afterwards. So having that monitor closely and maintain that euthyroid or restore that quickly as possible after surgery is very important. As far as progressions or changes of TED with thyroidectomy. I'm not familiar with any literature show that thyroidectomy is recommended to prevent or to cause regression of TED. But certainly, I think having a well-controlled euthyroid status with thyroidectomy is important to prevent progressions.
Awesome. Thank you. That was really helpful. I think I'm going to go to the next question, but when I'm going to call on somebody else, if you have anything to add to that, please do too as I go to that. But Dr. Van Landingham, maybe for you, you mentioned throughout the panel today a number of different treatments, biologics, steroids, surgeries. And there were a lot of questions from patients that came in about how do I talk to my doctor about what treatment's right for me at my time of, and what timing should I be looking at the different treatments. So maybe if you could help patients kind of how do they start that conversation with their doctors?
That's a great question. As I think a lot of people know, thyroid eye disease is really different for different patients. There are some treatments that are great, but not great for everyone. I think building and maintaining a relationship with a, specialist who sees a lot of thyroid eye disease patients is a great idea. I would say if there are specific treatments that you're really curious about, ask, is teprotumumab right for me? Is veligrotug, sorry, I'm still getting used to it. Is that right? Is that right? I don't know. Is that right for me? Ask, and then that person can kind of consider the question and the treatment for your specific situation. I think it's great to do sort of your own research, and I think everybody does nowadays. The internet puts all these tools right at our fingertips, and I think it's important in that context to be thoughtful, kind of about where you're looking. Like if you're looking, if you're interested in, say, clinical trials and new treatments available for thyroid eye disease, clinicaltrials.gov is a great resource. That's where all active clinical trials in the United States have to be registered. It doesn't always give a ton of detail, but at least gives you the outline and where the trials are being performed. I think also looking for websites that are hosted by, say, universities or like reputable medical organizations are also good. I think a lot of pharmaceutical companies have great resources out there, but I think we have to keep in mind where, of course, those are coming from. It's naturally going to be sort of geared toward the company's own treatments as well. So yeah, I think those are some things to keep in mind as you're starting to read and learn.
Awesome. Very helpful. And you actually answered another question we had about where can they go for information on new treatments that are coming out. So thank you for that. So I'm going to steal the last minute. Dr. Pakdel, I have one question for you. And you mentioned smoking. And there were a handful of questions asking, why does it seem that TED is becoming more common? What are the factors that influence its development, risk factors, but a lot of questions around the influence of hormones. So I was wondering if you could touch on that a little bit.
Actually, thyroid eye disease is like a multifactorial disease. You may consider like it's an interaction between the genetic treasure of each patient in terms of how the patient's immunity actually, and how is the tolerance for that immunity between different patients, and also in terms of the epigenetics. I mean that when you smoke, some genetic material may change inside your body, and the phenotype may change the genotype of some patients. This is one understanding that in some autoimmune disease, especially thyroid eye disease, matters a lot. So, changes in the immunity, and then the factors that can affect that immunity can be like epigenetic factor, like smoking, like emotional changes, like digestion, like even microbiome of the patients, that the bacterial flora inside your body can change your behavior of your immunity. And then when talking about the patient's age, sex, and different, available treatments, all of these matters. When we are talking about smoking, yes, smoking increase the emergence, actually happening of the thyroid eye disease in patients with Graves' disease. That's roughly about 50% of patients with Graves' disease finally may show some degree of thyroid eye disease. But if a person is smoking, it increases a lot, maybe 9 times more than those not smoking. And another thing, when somebody smokes, the response to treatment is coming down. What does it mean? It means that if the patient is continuing to smoke and the patient is receiving different medical and surgical treatments, IV methylprednisolone, teprotumumab, orbital decompression, eyelid surgery for strabismus, eyelids, but the patient smokes, the chance of the reactivation and non-responsiveness to treatment increase a lot. So all of this together means that we need to control every risk factor that we can control and pay attention to, the person by different perspectives, genetic material, epigenetics, environmental factors, available treatments, and all of this together by us bring up an image, what to do with this specific person and how to help this person.
Great, thank you. And we are at time, so I want to thank you. And I think I'm turning it back over to Christine to kick us off for the happy hour. Maybe? There's Christine.
I'm here. So, yeah, Jim, thanks so much. And Carol and Dr. Van Landingham. So I try on that. And Dr. Nguyen and Dr. Pakdel. Yeah, thank you so much for joining us. And yeah, really great answering all those questions and helping us find our way to Ned. So thank you for that. We are going to transition right now. We'll all be here, but what we do want to encourage is if you would like to stay and you would like to, please, you should be able to. Let me ask Eric. Eric's behind the scenes as the like our great person who's running everything. So Eric, if you could like let people turn on